Good evening, everyone. Welcome. Thanks so much for joining us on this chilly Thursday evening for this virtual UMiami Health Talk, New Advances in Bariatric Surgery. I'm health journalist Ileana Bravo. I'll be your moderator for this evening's webinar, which is presented by the University of Miami Health System's Department of Bariatric Surgery. UHealth is a regional leader in bariatric surgery. They're a department accredited by the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. They're a highly experienced team with leading outcomes. Their renowned program features the latest treatments with mind and body focused care before, during, and after surgery. So, if you would like to learn more about the University of Miami Health System's Bariatrics Department, please visit uhealthbariatrics.com, and to schedule a consult, call 305-689-1910. I know a few of you are just slowly coming onto our webinar tonight, and we're going to repeat all that information at the end, so don't worry, you are going to get a chance to absorb it later. But tonight, you're going to hear from the director of the program, Dr. Onur Kutlu, and bariatric surgeon, Dr. Robert Cubas. And at the end of the presentation, please join us for a Q&A session. It's a unique opportunity for you to ask direct questions of our experts, so don't waste that time. Enter your questions into the Q&A feature at the bottom of your Zoom screen. Take a moment to take a look at yours, and we'll prepare them for our experts to address. So let's kick things off with our first speaker, Dr. Onur Kutlu, the director of the Bariatric Surgery and Metabolic Health Program at the University of Miami Miller School of Medicine. Dr. Kutlu is a nationally recognized surgeon specializing in advanced and complex weight loss and digestive system surgeries, including care for patients with serious medical conditions. Dr. Kutlu is known for his minimally invasive approach and his focus on helping patients improve their long-term health and, of course, their quality of life. He is an often invited speaker on the latest advances in bariatric and metabolic surgery. So please join me in welcoming Dr. Kutlu. If you're ready to go, Dr. Kutlu, make sure you are unmuted.
Perfect. First of all, thank you very much for hosting us tonight. University of Miami is one of the few centers in the country that offers complex bariatric surgery care. We are the only academic center in South Florida, and we're a comprehensive center of excellence designated by the American College of Surgeons. We take care of patients ranging from age 15 and above, and we take care of often revisions and failed weight loss surgery. And we take care of patients with extremes of obesity, often weighing more than 400 pounds. Many of our patients have chronic diseases, including heart, kidney, liver, and lung failure. They're transplant recipients, and we are an international referral center for complex care of these patients. But year to year, we have award-winning outcomes, and we are one of the few centers in the country that has a dedicated patient care for bariatric surgery patients, and we have designated nursing staff and facilities. Now, if you are in this talk, please understand that you're not alone. In the United States, 75% of the adults are overweight, and almost 26 million Americans are above the thresholds for getting weight loss surgery. Recently, obesity and its complications are the second most common cause of preventable death in the United States after smoking. This is not a willpower problem. It is not an eating problem. It's morbid obesity is a disease. It's not your fault, and it should be treated like a disease. Now, the definition of morbid obesity is calculated by a measurement system called BMI. If you Google BMI calculator, you can put your weight and height on it and see where you stay there. But as a rule of thumb, if your BMI is over 40, or if you're 100 pounds overweight, you are in the morbid obesity category. Now, the issue is this is not a weight problem. When you reach the point of morbid obesity, your chance of developing heart disease like heart failure, stroke, and heart attacks is 3 times higher. Your chance of getting diabetes is 3 times higher, twice as higher risk of cancers, lung disease, and liver disease. However, the most concerning part for us is there is strong relationship with cancer, especially in women. If you're morbidly obese, your chance of developing endometrial and breast cancer is 4 times elevated. And the other cancers are almost twice as higher in men also. So the big picture is this. Once you reach the point of morbid obesity, your life expectancy decreases as much as having stage 3 breast cancer or stage 2 colon cancer. This is a disease that needs to be treated. However, there's a solution for this. That's why we're here for. Now, we are focused on your well-being beyond your weight loss. We want to cure your diabetes, your heart disease, your liver disease, even relationship problems, depression, and decreased life expectancy. That's why we have this comprehensive center for. Our goal is to help you live a longer, fulfilling, and a better life free from the constraints of obesity. Now, at our center, we offer all the surgical procedures that are accepted by the international governing bodies and the American Society of Metabolic and Bariatric Surgery. We perform gastric sleeves, bypass, duodenal switch, and the mini gastric bypass. Now, I often get asked, what do these operations do? Now, we do these operations through 8mm incisions smaller than the nail of your pinky. Oftentimes, these operations last from 45 minutes, for more extensive operations to 2 hours. Most of our patients go home the next day, but some stay 2 nights. There's rapid return to daily activities and minimal discomfort after these operations. The gastric sleeve is the most commonly performed procedure. More than 150,000 cases are being done in America every year. It's a very effective operation with resulting in 65 to 70% of excess weight loss in our patients. And within months after the operation, many of our patients are free of diabetes medications and high blood pressure medications. On the other hand, until recently, gastric bypass was the most common operation. We reserve this for our patients that are a little bit higher weights or have badly uncontrolled diabetes. It's a very effective operation, 70 to 75% excess weight loss, and rapid resolution of diabetes, often in patients before even they leave the hospital 2 days or even the next day. It is done by creating a small pouch of the stomach and connecting to the intestines. It's a 1-hour procedure. But sometimes we get our patients who are 350 pounds, 400 pounds, 500 pounds. In that weight group, if you're especially if you're diabetic, the duodenal switch, which is combined with a bypass and a sleeve gastrectomy to say, is an extremely powerful operation. It'll be reserved for high weight patients, 85% excess weight loss, and it is the most effective treatment for diabetes and super obesity and other issues that happen with obesity. Thousands of cases are being done in the United States each year. It's increasing, and it is very effective if previous weight loss surgery fails and the patients don't get the results they wish for. On the other hand, we also perform the mini gastric bypass. This is the most commonly performed bypass operation around the world, and I used to do this more than 20 years ago. Short operative time, simple anatomy, 70 to 75% excess weight loss, recently approved in the United States, and thousands of cases are being done around the world each year, and it's very effective for resolution of diabetes. If you look at this chart, you will see that with operations, as the operations change, there is significant improvement in diabetes, high blood pressure, sleep apnea, 80% of the cases, cholesterol levels, and heartburn, and issues like that. But the best thing is, after bariatric surgery, this is the most important part. Your risk of developing cancer is almost half if there is obesity associated. And often I get asked this question, why surgery? There are all these medications. Why can we not do exercise and diets and medication plans? So when you look at this data, this is from the United Kingdom. Once you reach a point of morbid obesity, your chances of going back to your normal weight and keeping there is less than 1 in 1,000 for men and less than 1 in 600 for women. Now, and then there are all these new injectable medications that we're hearing about. This chart is from the manufacturer's website directly. These medications work, and we love them for our patients if they're not in that surgery category, and we offer it in our program. But once you reach the point of morbid obesity, even if you continue the medication, 1 year later, the weight loss plateaus at around 20% or so. And if you stop the medication because of side effects or costs or other issues, the weight gain happens. currently, most of the patients that we see in the bariatric surgery program have used these medications before. And if you look at the data from long-term follow-up of these medications, we know the weight loss is much less with the medication, but we also don't see the reduction in 10-year mortality, which we see with bariatric surgery. That's why we like to perform surgery if you're morbidly obese. Basically, surgery cures disease and decreases deaths from future medical events. This is due to the resolution of morbid conditions such as diabetes and high blood pressure and vascular disease. I would like to return the podium.
Thank you.
Thank you.
Thank you, Dr. Kutlu. Okay, great. And we'll be back to you, as we discussed in a little bit, for you to talk about the comprehensive approach that your department takes to the before and after surgery and the support of patients. So we'll come back to you. But our next speaker for the moment is Dr. Robert Cubas, an assistant professor of surgery at the University of Miami Miller School of Medicine. He specializes in minimally invasive and robotic surgery, helping patients recover faster with less pain and scarring. Trained in both the United States and Argentina, Dr. Cubas completed advanced fellowships in gastrointestinal surgery and surgical endoscopy. He uses the latest technologies, including robotic-assisted surgery, to perform precise and complex procedures. Dr. Cubas is actively involved in research and is a member of several national surgical organizations, always staying at the forefront of advances in patient care. Welcome, Dr. Cubas.
Thank you so much for the presentation. Well, I'm going to talk about advances in bariatric surgery, what tools we have to help you with your journey. So the first one is robotic surgery. Robotic surgery has been around for several years already, been used for many procedures in the abdomen and the thorax. We have seen that since 2015, there has been an exponential growth in the use of robotic technology for bariatric surgeries. In 2025, just last year, we acquired the latest version of the Da Vinci, which is the most used robotic system in the US and in the world, the DB5. We were one of the first hospitals in the country to acquire it. And it's very important because it has increased processing power, haptic feedback. Now this new robot gives us a feedback on where we're pulling too much on the tissues or giving too much traction on the tissues that we didn't have with the previous technology. And the 4K imaging, ultra high definition. So the visualization of the tissues inside is incredible. So, and also the AI capabilities. Now, this new technology is acquiring a lot of data from surgeons around the world that are using this technology. So in the future, we're going to see robots that are going to guide young surgeons to do operation more safely. Dr. Kutlu mentioned about the surgeries that we mostly perform. I just put here the first two that we do the most, which is the gastric sleeve and the gastric bypass. We have seen that since 2015, we have seen an exponential growth in the use of robotic surgery to perform these procedures. Back in 2015, only 7% of them were done with a robot. And now in 2026, we're seeing that almost 40% to 50% of the operations are done with a robot. And why robotic surgery? Because it has enhanced vision, as we mentioned before. It has ultra high definition. It has greater dexterity. It has a feature that is called Firefly. I'm going to explain to you what it is. We inject a dye on the patient that then it distributes through the blood flow in the patient. And when we're doing the operation, the robot can capture that. So when we're cutting through tissue, we can exactly see if that tissue is well perfused. It has good blood supply. And so if we don't see that, then we don't cut through that tissue. So it gives us additional tools to make the surgery safer. And what are the benefits for the patient? Well, it's being known that it creates less scarring because we use small incisions to do the operation. There is reduced blood loss, reduced pain, shorter hospital stay. Our patients go home the very next day of the operation, sometimes 2 days, but most of the patients go the next day of the operation, which brings a quicker recovery for them. And for the surgeon, where you mentioned the greater dexterity, we feel like we're actually operating inside of the patient through tiny incisions, like we were doing open surgery. The improved visualization, the enhanced precision and tremor filtration. If your surgeon has tremors, then the robot will filtrate those tremors. It's ideal for complex procedures, especially when we do redo or revisions or patients that had an operation before. I see a great benefit using the robot. In the ergonomic benefits, you can see on the picture here, this surgeon is standing up, sometimes in awkward positions all day, versus this other surgeon here sitting up, operating in a console in a very comfortable way. Who's a candidate? As Dr. Kutlu mentioned before, well, anybody that has a BMI over 40 or those that have a BMI over 35 and a significant obesity-related comorbidity like high blood pressure, diabetes, sleep apnea, etc., and they have a previous weight loss efforts. And very important is that the patients have a commitment to lifestyle changes. These are good tools, the most powerful tools that we have to help you in your journey, but we also need a commitment from our patients to lifestyle changes. In terms of health and readiness, if for some reason you are not healthy to undergo surgery, we're going to provide you with a specialist to make sure that you are ready for that surgery. Now, let me talk to you about endoscopic gastroplasty. That's another tool that we have. It's being done via a tool that is called the overstitch. It's been around for several years, but it hasn't been until 2022 that it got approved by the FDA to perform what we call endoscopic sleeve gastroplasty. That same year, the company that used to produce this device, the name was Apollo, was acquired by Boston Scientific. And Boston Scientific has done a significant amount of work to make this device more available for the patients. Just this year, we have a CPT code. And what is a CPT code? A CPT code is a code that is assigned by the American Medical Association for every procedure that we as surgeons do. There is a CPT code assigned, so insurance can be billed for it. So we are seeing already that some insurance are starting to cover this procedure. In the coming months and years, we're going to see more and more insurances covering for this procedure that used to be out of pocket in the past. And why endoscopic gastroplasty? Because it's an alternative to those that don't want surgery. It's an alternative for those that don't want medications or that have tried medication, but then they regain the weight. No organ or tissue is removed on this procedure. You can expect a total body weight loss of 15 to 20%. And the most important part is that it's incisionless. We don't have to make any incision. Everything is done through the mouth. Who is a candidate? Anybody that has a BMI over 30, up to 50, and that has failed to lose or maintain weight loss with other conservative measures. Who is not a candidate? Anybody that can undergo endoscopy. If you have an altered anatomy, or you have surgery in the past in your stomach or your esophagus, you may not be a candidate for it. If there is presence of malignant tissue, or you have a hiatal hernia, like this one, hiatal hernia, when you have a piece of your stomach back up in your chest, you may not be a candidate for it. Bleeding disorders, if you are pregnant, uncontrolled affective or eating disorders also may disqualify you for it. But I mean, if we had it under control, if you've been seen by a psychologist and we treat that, and they clear you for the procedure, then you may be amenable to undergo the procedure as well. Then you're going to hear about this new technology, magnetic surgery. Basically, it's creating connections in the small intestine using magnets. It's produced by this company that is called GT Metabolic. It has been cleared by the FDA since 2024. Have demonstrated that there's risk of leaks and bleeding according to the data that they show. It's a new technology, it's available, but we have to see you qualify for it or not. We sometimes don't think that it's better than what we already have. So, but it's a tool that we have available just to for certain patients. And again, you just need to talk to us about if you are interested in you qualify for it. Then this technology, EndoBarrier, it's not commercially available. It's basically a sleeve, as you can see here in this picture. It looks like a plastic bag that we place endoscopically. It's commercially available in Europe already. It's not FDA approved. We're still working on it. It's under trial. The University of Miami is one of the centers that is working on the trial. And we expect to finalize the recruitment by the end of this year. According to the data published in Europe, it has shown to decrease the weight in about 15 to 20%, and to decrease the A1C. You know, the A1C, the number that we for those that have diabetes, that's the number that we use to measure the severity of your diabetes. And this device has shown to drop that number in 1.5%. The way it works is basically it is placed inside of the intestine, and when the food goes through, it bypasses of the segment of intestine, similar to what happens when you do a gastric bypass. And that's basically how it works. It's meant for patients that have diabetes and obesity with a BMI over 30. So, well, that's all that we have nowadays. But basically, the two most important technologies about the ones that I just talked about are the robotic surgery technique and the gastroplasty. Those are the two most important tools that we have available for our patients nowadays. Thank you.
Thank you, Dr. Cubas. Okay, so let's go back to Dr. Kutlu, as we discussed, because this is indeed a journey to get to the before surgery, after surgery, and then the multidisciplinary approach that you have in your department and at the University of Miami Health System to begin with to support these patients. So Dr. Kutlu, you're up again, please.
Thank you very much. Now, this entire center of excellence we have built at the university is centered, is built around the patient at the center. So we provide integrated care to the obese patient in collaboration with other specialties. So the patients don't have to look for doctors. We have everyone on board in the university system. We provide individualized care to our patients.
I think we need to see your presentation because we're not seeing your slides.
I'm sorry, 1 second.
Okay, probably
Okay.
Dr. Cubas.
Yes. Okay.
There we go.
Can you see it now?
Yes.
Perfect. Okay. The center of excellence is built around the patient. We provide integrated care that's built around the patient with multiple specialties, so our patients do not have to look for doctors if they have any other illnesses that are happening to them. And here, we provide individualized care to every patient, such as if you're not so much overweight, we can provide you the injections and the appetite suppressants medical weight loss treatment. But also, if you don't want to get surgery, if you're not a candidate for this, we can provide you endoscopic treatments that Dr. Cubas has explained. We also perform bariatric surgery ranging from the less invasive ones to the operations that are reserved for very high-risk patients too. And the beauty of being at this institution is you can provide seamless follow-up and monitoring for all patients, including medical weight loss patients. We have postoperative support groups. We perform body anthropometric analysis. We can look at muscle and fat mass in every segment of your body, your arm, your legs, your right leg, your back, your front, and see how you're changing and progressing over time. And we can look at your metabolic parameters to see how your body works over time. So when you come to our center, first of all, you get consultation with the physicians and see Dr. Cubas or myself, Dr. K, my patients call me, and we all speak with other specialists and physicians in the university system to see how we can help you. You will get a psychological evaluation per Center of Excellence guidelines, nutrition evaluation and counseling. All the lab works and studies are going to be done. And if necessary, we will get other specialties involved in your care to make sure that you're taken well care of. After the surgery, our patients are admitted to a bariatric center of excellence floor at the university, and they have designated nursing staff for them. Our patients get up and walk immediately, start drinking after a couple of hours after the operation. Hours after, nutritionists start seeing them and just explain them what to do in the upcoming days. Physical therapy visits them, helps them with their mobilization. If they're diabetic, diabetes and endocrinology services come and see them, as well as other specialties if necessary. 85% of our patients go home the next day after the operation. Most of our patients do not use any pain medications after 2 days. We obviously give them the pain pills, but they just tell us, hey, doc, I didn't need the pain medication, so I'm fine. You can drive 72 hours later, 3 days later, and the only reason is if the anesthesia doesn't wear off completely, we don't want you to get in a traffic accident. We recommend usually taking 1 week off from work. We want you to rest and have spent time with your family. And most of our patients go home with a liquid diet. They're not hungry anyway. And then as time passes, they slowly advance to purees and increase the amount they eat. The interesting part is there's rapid weight loss phase in the first month, which reaches up to 30 pounds, sometimes higher, depending on the amount of weight that you need to lose. And also, again, the system is based around the patient here. Each patient that comes to our Center of Excellence is provided with a personal advocate and a direct phone number to them, so they don't have to search for a doctor or for someone else. These advocates, they have all your information ready. They can help you with your appointments. They can help other coordination, other specialties, and they can help you schedule your tests and other whatever is needed for your care. So after surgery, we want to be your friends. You're now a part of our family. We like to see you. We perform surgical follow-ups, medical follow-ups to see how you're doing. There's this constant nutritional counseling. We have exercise programs and support groups, and we like to coordinate care with other specialties, even if it's beyond our specialty, so all your care is taken care of. The beauty of our center is we have 3 nutritionists on board with us that are dedicated bariatric surgery nutritionists. One is a PhD, the other one has been doing this for more than 20 years. Another nutritionist has certification in diabetes. Many centers do not have this. We do preoperative one-on-one evaluation, pre-op classes, medically supervised weight loss programs like the GLP-1s and those injections and pills. We have postoperative classes, and we have a bariatric coordinator whose entire job is to make sure that this system works flawlessly. We also have 2 wonderful, very talented, very knowledgeable and experienced nurse practitioners. They offer our patients medically supervised weight loss programs such as the GLP-1s, the injections, the appetite suppressants. They're responsible for managing your prescriptions are ready. They provide you follow-up care, and they help us with the initial health examination and physical examination. So even if you're not thinking about surgery, just make an appointment. Start now. We can help you, and we have solutions for the issues that you're having because of the weight problem that you have. We want you to live a longer, better, healthier, and a happier and a more successful life. This is a disease. It's not a problem of willpower. It's not an eating disorder, and definitely is not your fault. You have options, and we're here to help. Thank you very much for the opportunity to speak to you guys today. We're honored to be here in front of you.
Thank you so much, Dr. Kutlu and Dr. Cubas. It's such an important topic, and we're going to launch the Q&A, the question and answer session now. So remember, all of you who are tuned in with us, all you registered, see that Q&A box with a big question mark. That's where you can enter your questions so that we can field them. But let's start off with, you just explained, Dr. Kutlu, how comprehensive this process is within the department, all the different people with specialty areas. So from beginning to end, from the pre-assessment of the patient and sort of qualifying them for the procedure, how long is the process?
That's a very good question. Thank you. Now, the most important thing for us is to make sure that you are safe. Everything is in order, right? When someone walks into our door, I personally want to understand what you want from me. Is it the weight loss? What's your long-term goal in this, right? We have a visit. We ask 100 questions approximately to understand what your past is, and if we see any red flags, especially oftentimes what happens is when a patient is obese, they have very bad diabetes or uncontrolled diabetes, some heart disease that's underlying that they're not even aware of. In all these pictures in Indian society, you see there's a smiling, very happy, overweight person, but in fact, there is some problem that's brewing inside. Often people are not aware of. I want to make sure that we're not missing it. So it takes around, and then we get you to see our team, nutritionists, and other members of our staff. Normally, this process takes around like 1 month or so for us to get a complete picture of you and to understand how we can help you. However, as you know, in the United States, each insurance has a different requirement. After that time, the time that you wait is usually dependent on what your insurance requirements are. Some insurance require you to have 6 nutritionist visits, but if you have Medicare or some other federal insurance, only 1 visit is enough. So when you walk in through the door, the shortest time period would be something around like 1.5 hours. And it can go longer depending on what your insurance needs and how your overall medical condition is.
Okay. Before I jump to Dr. Cubas, one more thing then.
Yes.
Is psychological assessment a key component, sort of the buy-in that this patient is ready psychologically to do this? This is a dramatic and drastic step.
But that's also a very good point. The main reason that we get the psychological assessment is, first of all, it's a requirement that's been set forth by the international bodies regarding obesity. The second thing is, this is happening to the patient, but why is it happening, right? There's a pathological connection with food to comfort. So if we catch that component before, that increases the chance of success in the long run. So because it is very important to know yourself. So when the patient understands, in fact, eating is a stress response for them, after surgery, if a stressful situation happens, they know how to control it, and it's easier for compliance. And also we want to understand who you are and what your expectations are. It is very important, and our psychologist in our department, she specializes in this. All she does is psychological assessment and treatment of patients who are suffering from obesity.
So, Dr. Cubas, you gave us a bunch of different options of the different surgical procedures available, the robotic assisted, even the AI guided, that we're sort of moving in that direction because, of course, why wouldn't we? So this ESG one, the endoscopic one that you talked about, seems to me to be the least invasive, if you will. It doesn't even require incision. Why wouldn't you move more patients in that direction instead of the more open kind of surgeries?
A very interesting question. Well, because the data has shown that even though it's a good technique, it hasn't shown the amount of weight loss that we have seen with the other procedures. We're talking about 15 to 20% of total body weight loss with ESG versus the 30, 35, 40% with the other procedures. And Obviously, not everybody qualifies for ESG. As I mentioned, there are some caveats, but that's mainly the issue. We have more data from the other more invasive, let's say invasive. There are minimal invasive procedures, but because this is a novel technology, we still haven't seen that. So I see ESG as a bridge to that gap between patients that are on medication and the patients that want surgery. So you are that patient that don't want medication but also don't want surgery. Well, probably ESG is a good fit for you.
Yeah.
But
And
still, I see patients in the clinic asking me for ESG that I tell them, you know what? Yeah, ESG is a good tool, but you may be a candidate for the other procedure, which is more durable, and we will have more data, and we know that you are going to do better with these other procedures that we already know.
yeah, because why wouldn't a patient want the one that is the least invasive, of course? But I hear from what your presentation that what you're saying is that technology is moving in that direction. We're just not there yet. But that's the goal, less trauma to the patient. But let's jump into some of the questions that we had pre-sent to us. I think you were saying this, that you can have revision surgery for bariatrics. So you can have it more than once?
Correct. Yes. Depending on the type of surgery that you had. Oftentimes, what we see is this. Many patients go out of the country to get surgeries because they find it more affordable to go there. And although there are many good physicians outside the country, patients choose the cheapest option that's in the country that they're going to, and we don't know who these people are. Now, the issue is oftentimes we see patients who had suboptimal operations which were not done to the standards that we do the operations, or sometimes people are lost to follow up, and sometimes life happens, right? So in those situations, depending on the type of surgery, we have options, and we can convert those procedures. If they were not done the right way, we can take care of that. And if someone has a problem elsewhere, and they don't have anyone to take care of them, we just take those patients also. We not only take care of patients who had whose weight loss surgery did not result in the expected outcomes, but we also take care of the patients who had problems with surgery, but from other physicians and surgeons.
And of course, UHealth Center of Excellence probably is doing more of these revisions that were not done there before. And therefore,
correct. Yes, the Center of Excellence designation provides us with licensure to perform revisional complex bariatric surgery.
Here's a question that just came in from the Q&A box. I've heard that heartburn is a major side effect after the surgery. I don't have heartburn now and don't want to develop it after the surgery. Is this avoidable? Is it a common thing
Yeah, that's also a very good question. So the heartburn is sometimes seen after weight loss surgery, especially the gastric sleeve operations. And the reason is, first of all, again, we're talking about surgery that needs to be done based on the specifications, right? Like how it should be done. Now, the issue is when we do our workup, all of our patients get some sort of x-ray of their stomach with a contrast material, and we look to see if there's reflux in these patients. Oftentimes people are aware that they don't have this reflux. So if you have weight loss surgery and you already have a problem in the valve up here, if we don't take care of it at the time of surgery, which only adds 10 minutes to the operation, maybe 20 minutes to the operation, you may have weight loss. Sorry, you may have reflux. Yes, that's a possibility, but that rate is exceedingly low if the appropriate pre-op workup is done, and if we take care of it at the time of surgery. And Dr. Cubas, I believe, practices the same way.
Yeah.
Right.
And this question is, can the procedure help with Barrett esophagus?
That's also a very good question. For Barrett's esophagus patients, especially, as you know, for the ones in this talk that don't know what Barrett's is, it is that the reflux into your esophagus, the acid burns the esophagus so much, the cells over there basically say, hey guys, I don't want to play this game anymore. I'm converting to intestinal cells. Now, when this happens, it means that you're now dealing with a precancerous problem, right? It has to be taken care of. When a patient comes to me with Barrett's esophagus, I just tell them, look, bypass is the ultimate operation for this. It will take care of the reflux. It will take care of the Barrett's. And in fact, even if you're not in the morbid obesity range, if you have esophageal problems, bypass is offered for the treatment of these conditions. If you're morbidly obese, if you have Barrett's, please get this taken care of.
This would be for the women in the audience, that do these surgeries cause any potential pregnancy risks later in life? And if so, what are the risks, and would surgery still be the best option?
You know what? That's a beautiful question. So let me tell you what. So oftentimes something happens, right? The hormonal imbalance is so serious in patients with morbid obesity. Often people cannot conceive. And it's a huge stress for women who are morbidly obese. And what I get is, I tell my patients, look, I'm going to do this operation on you, but please do not get pregnant for 1 year at least. Just give me a chance, okay? And they're like, no, we couldn't have a kid for 10 years, right? So as the hormonal imbalance corrects, someone who has tried to conceive for many years and calls me, hey, I'm pregnant, and my response, it's been 3 months only, right? So in fact, the pregnancy rates are much higher after surgery. Depending on the type of surgery, with appropriate follow-up, in the first, we don't recommend being pregnant in the first 15 months after surgery. However, with appropriate follow-up and vitamin supplementations and close follow-up, we do not see any issues with pregnancies. It does not affect the fetus.
Yeah, but as you said, it's true, the hormonal fluctuations would have to be massive. And so this is something to consider.
Yes.
All right, let's talk about what the entire country, if not the world, is talk about, the GLP-1s, the weight loss craze. Could this work in tandem with these procedures? Do you get to a point where you say, try this first, or is this population of obesity not even qualified to do the GLP-1s? Where are we with that?
So there are a lot of trials right now. I see obesity as a life-threatening disease like cancer. And how do we treat cancer? We treat them with medicine before surgery. We do the surgery, and the follow-up, we give medicine, right? We like to, as our center, decrease the patient's weight by a significant amount immediately before surgery. Surgery is safer. So I like to use medicines before surgery, not the GLP-1s, but the other types. So we're more ready for surgery. And in the future, after surgery, like a year and a half later, and they want to lose like 10, 15 more pounds, why not? We have it in our hands. And why reject it? And some patients are not candidates for surgery, and GLP-1s work very well too. So that's why we incorporated this into our practice. Is it going to cure morbid obesity? It's highly unlikely, but it's got its own spot. So there is no need to push these away. We incorporated them into our practice, and we embraced it. I'm sure Robert has other things to say.
Yes,
So
I'm
no,
curious, Dr.
the way I see it is it's bad to do comparison, but for example, the way we treat, for example, cancer is a multidisciplinary treatment. We treat them with surgery, with chemotherapies, radiotherapy. Well, that's the approach that we're trying nowadays to see obesity. So we not only treat it with one thing, but we can always treat it with multiple approaches. We can put these patients on medication, then we'll see how they do. If they do well, maybe they can continue with the medication. If they don't do well, then we can offer surgery. Or if we offer surgery and they start regaining weight, we can start doing some medication or evaluating if they are candidate for revision. So kind of a multi-approach of the problem, not just one for all.
Yeah, so the medicines, the GLP-1s, can be an adjunct to this whole holistic approach of the full patient.
Yes.
Yeah. Here's one that just came in. Let's take a quick look at this one. Is testosterone increased in men afterwards, and will the surgery improve sex life?
That's an excellent question. So here is the entire physiology of this business. Fat tissue in the body converts testosterone into estrogen. So your body may produce as much testosterone as it wants. If you have a lot of fat in your body, it's converted to estrogen by fat. That's why, in fact, the sex life is not as good as people would expect. After surgery, this conversion is no more. So your body's endogenous production of testosterone, although it's the same, it is not converted into estrogen, and you will feel the effects of this. Yes, definitely, your sex life is going to be better. Your energy levels are going to be much better. And with the buildup of muscles and other with exercise, it's going to be a complete different world. Testosterone is converted to estrogen if you're obese. After surgery, it increases.
I'm curious, are these conversations ones that you have with your patients all the time?
Yes.
Yeah, I would think.
Yeah, we have these conversations almost every day.
Mhm.
Yes, yes.
This question had come in earlier today, and I know it's almost impossible for you to answer this definitively, but this person says, I'm 4'9" and I weigh 160 pounds. Do I qualify for this process? I mean, impossible to say blindly like that.
And just for that,
So yeah, you're putting the BMI into
You
4'9".
have your calculator there.
Exactly, that's what he's doing. I don't know if it's a male or a female, but
it
nonetheless.
does not 4'9". What's the weight?
160, 160.
Second. Yeah, wait, BMI 34.6. Okay, so that's a very good question, right? If you were like a pound above in Europe, you qualify. So this patient's BMI is 34.6, right? In America, the current ASMBS guidelines state that if your BMI is over 35, you qualify for a surgery. The old guidelines were if your BMI was over 40. So this patient, if this patient was 163 pounds, that person would qualify for surgery. However, if this patient has diabetes, even if she was 20 pounds lighter, she would qualify for surgery because this time surgery is so effective in treatment of the diabetes and comorbid conditions, it prolongs life.
Yeah, yeah. Here's a question of somebody obviously who's in the thick of this, going through this. I've been seen by my endocrinologist a few times since I was diagnosed with type 2 diabetes. However, I'm aware my insurance does not cover any weight loss medication. Should I consider speaking to follow up? I've been denied twice for all the weight loss meds, plus I have a low pain tolerance to needles. Don't we all, right?
Yeah. Well, why don't you just come to us? It doesn't matter. We'll find a way to help you. We'll find a way to help you. Okay, your insurance doesn't cover it for one reason, but also the entire reason we have this framework is we have people and advocates that work with insurance companies if we can get them to pay for your needles, because other doctors' offices are focused on different types of disease. This program is designed for only one disease, right? So let's try to help you. Maybe there's other options. Maybe we can do it endoscopic sleep. Maybe we can do surgery on you. Robert can help you. I can help
do
you.
a combination of other medication, not just the GLP-1. We have other alternatives. We had medication before GLP-1 came on the
What are
market.
they, Dr. Cubas? Now that we don't remember, short memory, right? What are those medications that are part of your treatment?
Metformin is a very common medication used for diabetes that has been helping people to lose weight. Phentermine, those are the two most common that I use for my patients. There are more, not out of the top of my head, but
So in other words, there's plenty in your arsenal, in your tool kit.
armamentarium, yes, yes.
It dawns on me that we're talking so much about getting patients already at this morbidly obese level. Do you think that in the medical community or in this entire area of expertise of yours, we might be moving in a direction for prevention to catch patients before they get to this point, to the point of identifying, trying to to nip it in the bud, if you will? How do we treat the patient before they get to that point? What's the school of thought here in your entire specialty area?
It's a loaded question, but I would say that we will start with education,
Yeah.
educating our primary care physicians, educating our primary care physicians that in turn are going to educate the patients. And sometimes patients never have seen a dietitian. They only see the dietitian when they come to our clinic for surgery. And they can see them before to avoid going to that stage. And
Yeah.
and I don't see much referrals from PCPs to dietitians. They just go straight to surgery or to us. So if
Right.
they see a patient that is already overweight, probably they should refer this patient to a dietitian, right,
It
before
would
they
seem to
turn
be,
into this.
yeah, it would seem to be the perfect solution, in American medicine, so prevention, prevention, prevention. So if you all worked in tandem with the PCPs. This question just came over. How do these surgeries affect the signaling between the brain and the GI tract both ways?
That's a very good question.
These people are smart tonight that have tuned
Yes, so interesting. Whoever asked this question either read some of my papers or that person has been reading this stuff. Okay, so there is something called a gut-mind connection. Okay, um, I can talk about this for hours. Now the issue is this, especially with the gastric bypass. Once the food bypasses the duodenum, directly enters to the intestine, something miraculous happens, right? The entire GLP-1 medications came out from this. The intestine produces GLP-1 spike. It's just like getting that needle, but constantly, and hits the brain's satiety center. So you are not hungry. When you diet, and let's say that you break your diet, you eat the food, you're full, but you're still hungry, right? So this is the complete opposite. You have not eaten, but you're not hungry. So even a small amount of food gets that spike up. And also the insulin levels, instead of going steadily up, it's just one big hit and the brain registers the food, right? And with the gastric sleeve, we think that it's because the stomach is smaller, you don't eat much, right? And then it would have been like any other old weight loss options. But however, with the gastric sleeve, because the food is passing through the intestines fast, it has that GLP-1 effect. Also, the greater part of the stomach that we take out creates a hormone called ghrelin. Now, this is a very interesting hormone. It spikes 3 times a day, in the morning, at noontime, and at night. And guess what? Around 10 p.m. or so, it goes up a little bit. That's why you graze at night watching TV, right? That's gone. So now the food chatter in your mind is gone. You're eating to live. You're not living to eat.
Yeah. Wow. That's fascinating. We're getting close to closing, but we have a few minutes, and I think both of you, if you would please give us an overview and your sort of your feeling as to where we are, how far you've come in this area, in this specialty area, because you all said something interesting. It's not your fault. Guilt can be removed from the equation. It's not that they're overeating or they're not exercising. These are some genetic components, and I think it's sort of liberating for people to hear that, to say it's just not me being lazy. So please, both of you, give us some nice closing statements along these lines. Dr.
Well, I
Kutlu.
can start. I can say that again, it's not your fault. We know that obesity is a multifactorial problem, and we have all the tools and all the specialties available to help you with your journey. It's not just surgery. We're surgeons, we're also specialists in obesity. And so we're here to help you. I see a lot of people that don't qualify for surgery, but just because they don't qualify for surgery, I don't just walk them away. I help them. I tell them, hey, I can help you. I can help you. We have several tools to help you. We're going to start with this approach. We're going to send you to a dietitian. We're going to start this medication. I'm going to see you every month. Then I'm going to refer you to my other colleagues to start seeing you again. And if for some reason we don't get to manage that, we have other tools. We always have other tools to help you. If that doesn't work, we have some other option. So we have plenty of options to help you. And I think this is the best center for anyone that is going through this. Obesity is a problem, and so and we have solutions. That's all I can.
Thank you, Dr.
Okay, so here's what I believe. Here's what I believe is happening. So the first solution to any problem is to accept and understand that there is a problem, right? You can bury your head in the sand. For years and years, someone's obese, someone's overweight. What does the family tell them? Oh, you're lazy. Oh, eat less, walk more, do more exercise. Oh, I'm going to get surgery. I'm going to go to the doctor. Oh, you're lazy. It's a shortcut. No, please understand that we have a problem, and that problem is a disease called obesity. Right? Once you acknowledge that, you have a solution for it. Then you can decide on what to do and find a plan, do a plan, and go on with the plan. For years until now, the society, the doctors did not accept this as a problem. It was seen as a willpower. Oh, you're eating too much. You're doing this, you're doing that. But how do you explain this person who eats McDonald's every day and nothing happens to them, and this person who eats little and this happens? It's not that easy. It has been only until recently the doctors acknowledged this as a big problem. It's only recently now the society understands, hey, you know what? It may not be a simple issue as we think it is. So with the education, like Robert said, as the people, as the community, society is more aware that we're dealing with a very serious disease, we will find more and more effective problems, more and more effective solutions. And our job of medicine is to prevent disease, not to cure it. And hopefully we will be able to prevent this. So I will find another thing to do.
Yeah. So in many ways, the phenomenon that is the GLP-1s and the celebrity buy-in to the GLP-1s, in many ways has helped fuel what you do for the better.
Yes. That I totally yes, I believe that, and I completely support this, because whatever helps our patients, I'm going to embrace it. It doesn't have to be surgery. If we can fix it with a single pill, I'm going to work for that pill.
Yeah. Well, I cannot thank you both for the privilege of your time. You two experts at the top of your field, at the top of your game, taking the time on a chilly Thursday night for the benefit of this audience that's hanging on to all your information and your education. And to our audience, thank you for being so smart, showing so much initiative and jumping in there with all of us. We do appreciate everyone's time. So our program has ended for the moment, but you're all going to receive a link afterwards with the whole recording of the program about a week or so later. Just stay tuned to your emails. And we're going to put up the information on the screen now. Thank you both doctors so much. Thank you. On the screen, you're going to see how you get to get more information by visiting UHealthBariatrics.com. To schedule an appointment, which I think so many of you had so many interesting questions that you might just want to call this number and say, hey, I'd like to be seen. I'd like a consultation. To get the appointment, it's 305-689-1910. And that's how you're going to see some of the Center of Excellence in Bariatrics. Thank you so much for your time. And everyone, please have a great night. Stay warm. And most of all, stay healthy. Good night. Thanks.
Perfect. Thank you. Thank you.